Basically, I'm going to talk on the newer treatment modalities for complex SFA lesions. Uh, Basically, we going by history. If you see that we've been doing balloon angioplasties all these years, but saying that we had recoil, dissections, recurrences in 40% of the patients over in 6 months. So that's when the advent of the stents came in. And if you see the different trials that you saw between just simple PTA and stenting, there was a significant difference between just PTA and stents. However, we used to use stent as a scaffold. But saying that, there is a tremendous movement that occurs in the superficial femoral artery. Movements were like walking causes, or climbing upstairs, causes various forces to be exerted on the SFA, which includes flexion, longitudinal and lateral compression, torsion, and increased risk of stent fracture and restenosis. So if you can see this diagram, which actually will show you what are the different forces that are exerted on the SFA. So stents as a scaffold, what were the results? There was about 2 to 3% thrombosis. In-stent stenosis about 6 to 8%. There was recurrence, proximal or distal, which was 8 to 10%, and stent fractures over 8 to 10% in 1 year. So it was, we are looking at evolution of the different types of treatment for SFA. So you could have in-stent stenosis, extra stent, neo-intimal hyperplasia, and of course recoil. So what is the causes of restenosis in the stents? It all depends on the metal used, whether it's stainless steel or nitinol. Stent design, longer length of the stents, the more the possibility of in-stent stenosis. If you put multiple stents or overlap, that is a problem. Stress zones and causes a fracture of the stents. Stent across a joint is a no-no. Untreated segments can cause restenosis, and of course, whatever barotrauma that you have when you do the angioplasty. So what are the new techniques that evolved? There was drug-coated balloons. There was atherectomy with drug-eluting balloons, drug-eluting stents, biomimetic stents. Now the new kid on the block is intravascular lithotripsy. And the way to go, I would think, would be bioabsorbable stents, especially in the SFA. So we all know what the I won't go too much into detail, how the drug-eluting balloon works. Basically, it is a antimitotic drug which prevents neo-intimal hyperplasia. So there are studies which show if the restenosis is less when you use a drug-eluting balloon compared to plain simple balloon, compare it to 27% and 65%. So these are a few examples of them. You are seeing that there is a in-stent stenosis, and we use a drug-eluting balloon to obliterate the stenosis, as well as give the drug to prevent restenosis from occurring. So then came the silver first peripheral drug-eluting stent. Now there is Eluvia, which has come from Boston. Silver PTX was from Cook. That showed promising results. If you see re-intervention, no re-intervention in 89%, and re-intervention in only 11%. Whereas if you look at the bare metal stents, it was 77% no intervention and 23% in re-intervention. So what does it do? Basically, it is a breakthrough technology. It's the drug that causes the effect. And definitely the results were better with drug-eluting stents. So 1 year patency was about 90% in these patients, and 72% 5-year patency rate was a very good result. So it was basically anti-proliferative drug, efficient drug delivery, and it also supports the vessel. So giving you an example now of all the technologies that we've talked about, this is a 68-year-old male, diabetes with ex-smoker, had an ulcer in the foot. We decided to do an atherectomy for him. Here you can see this is a directional atherectomy, what we call Turbo Hawk or Hawk 1 now. And after that, we used a drug-eluting balloon, and the results were excellent. So this is the definitive AR pilot study which was done, which clearly shows that there is a 24-month follow-up is ongoing, and the assessment of these patients looks very, very promising. So this is another example. When you have an eccentric plaque, you can have a directional atherectomy, which will actually cut off the plaque from the lumen, and you get a nearly stent-like result without putting a stent. If you have it in the tibials, again, it's another eccentric plaque that you can see here, as well as another one here. And we have done an atherectomy, and you can see the good result. But of course, we have used drug-coated balloons in these cases. Another example is across a joint where you cannot put a stent. We have definitely had better results with atherectomy. This is a total occlusion. We have done an atherectomy and then used a drug-eluting balloon. So this is another place where you can use atherectomy is in stent, though it's off-label use. We have used it quite a few times. We have got good results with atherectomy within the stent, and thereafter a drug-eluting balloon. This is what the results look like. Well, the plaque that is excised, you can get plaques like this when you remove the HOC1 device. Now, this is another patient, an 84-year-old male, hypertensive, diabetic, long-standing lower limb claudication. He had a CABG 2 years ago, lower limb angio done with coronary angio, the critical SFA stenosis, presented with lifestyle-limiting claudication, posted for angio and revascularization. This is the angio. You're seeing a diffusely diseased SFA, total occlusion with gross calcium at the adductor hiatus, and comparatively decent distal runoff. So we used a distal protection device. This is the microcatheter going across. We are delivering the distal protection device. We used a pre-dilatation so that your HOC1 device can go across. And this is the atherectomy device. You can see it jump where it's cutting the calcium. And after the atherectomy, we are seeing a pretty decent revascularization of that segment. However, if you see in the right picture, you can see some filling defects within the filter, which is the plaque which has got dislodged and caught in the filter. That is why it is important that one uses a distal protection device. And of course, this was a little earlier, so we did put a stent in this patient. And with the follow-up of this patient, the stent is still patent. But ideally speaking, today I would just use this. This was the time there was no drug balloon available. So this is the final result. We have newer techniques. If you cannot get cross antegrade, we go retrograde. We puncture the tibial vessels and do a rendezvous technique, snare the wire, and then continue with the angioplasty. We have biometric stents available, which is basically from Abbott. It's called the Supera, which is a very flexible stent, and it's a nitinol woven stent, which has shown very good results when there is gross calcium. And if you see freedom from TLR, 12 months was 91.3, 24 months was 86.7, and 36 months was 81.6. So I won't go too much into detail. As I said, the newer kid on the block is also the drug-eluting biodegradable stent. We have done trials which have shown pretty good result, and we will wait for the final approval before it comes into the market. Now, this is a 57-year-old male patient, diabetic for 20 years. I had a history of diabetic foot and amputation of second, third, and fourth toes, presented with severe leg pain, with spreading cellulitis and non-healing ulcer of the right foot. So this is what the ulcer looked like. There was definitely something need to be done. We've done the Doppler, which showed that there was extensive disease. And when we did the angio, you can see there is a total occlusion of the SFA just distal from to its origin, as well as another occlusion at the popliteal level across the joint. This is the distal runoff, which is a single vessel anterior tibial runoff. We've gone across with the wire, pre-dilated the whole segment, and then we put a supera and overlapped it with two superas, and we got a good result. Now, the last and final would be IVL, which is intravascular lithotripsy. It is comparatively new in this country, but has a great role to play when you have gross calcium. Most of the time, we can get away without stenting the lesion, but just using intravascular lithotripsy. So this is how it works. You have a balloon which is not at very high pressures. You inflate the balloon and then apply the ultrasound waves, which basically crack the calcium. And this is what the picture looks like before, and this is what the picture looks like. You can see the cracks develop within the calcium, and it gives a better compliance for the vessel and opens it up. An example of this is in this patient is the SFA, distal SFA. We've managed to cross. We've balloon dilated it. Thereafter, we've used the intravascular lithotripsy. And if you see here, without the need for a stent, we've got an excellent result. So I won't go too much into the details of it because I don't have the time. But suffice it to say that Disrupt PDA trial was very good. The IVL was superior to PTA in acute procedural success and demonstrated atraumatic treatment, reduction in the diameter, percentage diameter stenosis prior to the DCB or stent placement, lower maximum inflation pressure, reduction in frequency and severity of dissection, and lower post-dilatation and stent implantation rate. That's why we say that don't leave anything behind. So you need not put any stent. And most important is that you have to try and get the flow within the SFA to get a distal good runoff. So basically it is to restore the arterial supply before you debride or do any local amputation. That is legs, save legs and save lives. Thank you.